everyone. Welcome to Cheer Seminar. We've got a kind of a weird month of cheer seminars coming up, so I'll do announcements about that, and then I'll introduce Kao, including at least one fun fact. So we have cheer seminar today. Thank you for Kao for stepping in. I now owe him probably 3 quick presentations due to him taking the state for us. Next week on Tuesday morning, we have abstract review, PAS abstract review. Kao, I know, is submitting 4 abstracts. If anyone can beat him, I will buy you pizza. And so I know that Joanne will have one and Missy will have one. So anybody that has an abstract that's being submitted to PAS, please bring it for group discussion on Tuesday. And then the next week is Halloween. And also, since it's the 5th week, we are off every time there's a 5th week in. And then we start again the next week with Sarah Lang-Callow presenting for our cheer seminar. So there is our month. And today I would like to welcome Dr. Kao-Ping Chua to present for us. We all know him. He is a general pediatrician and a health services researcher. He did his residency at Boston Children's Hospital and then got a PhD in a typical Kao overachieving fashion at Harvard in 2015 in health policy. He's often in JAMA. I joke almost every month we have a Kao publication in JAMA. And our fun facts for the day are that in December, he was on the Today Show. Last week, he was interviewed by NPR, and he is a very adamant Lions fan. So those are.
That is true. That, of course. And another fun fact is he's going down this week in fantasy.
Oh my
football.
God. Gary has an amazing fantasy football team. Let's put it that way.
All right, so go ahead, Kao.
All right, thanks, Ed.
Let me share. Trash talk, you know, just we're facing up.
All right, so I am going to talk today about.
It's really neat, that's what was since you screwed up. There's like one of those like 9 p.m. on Wednesday night games and you don't have your roster set.
Okay, so the title of my talk is why should we care about providing pediatric care? I don't have any conflicts of interest to disclose. I'm going to start, this talk is in 4 parts. I'm going to start by with the basic question, why should we care about this topic? Then I'm going to present some of my empirical studies on the prevalence and burden of that care. I'm going to kind of delve into why low-value pediatric care occurs, and then end by talking about what we can do to reduce low-value pediatric care. So when we talk about low-value pediatric care, we need to start with what is value, right? So we need a definition of value. One of the most commonly cited definitions comes from Michael Porter from the Harvard Business School, who defines value as outcomes over spending. So essentially health benefits per dollar spent. So it follows that low-value care is care that decreases the ratio of outcomes to spending. So the most obvious example of that is care that doesn't improve outcomes or even worsens them while increasing spending, for example, antibiotics for colds. Another more subtle example is care that has a positive benefit, but at a very high cost, essentially an unfavorable cost to benefit ratio. So for example, if you conducted cervical cancer screening for all young female adolescents, you would detect the case of early cervical cancer, but you would have to screen so many people in order to do that it's just not cost effective. Now, why should we care about improving value, right? It's kind of obvious that the numerator outcomes, we should all be interested in improving outcomes. That is the point of the healthcare system. Really, the key is the denominator, which is healthcare spending. Why is high healthcare spending a problem? Well, this is very well put by David Cutler in a healthcare article a couple of years ago, who basically argued that high healthcare spending has numerous costs, among them that it worsens income inequality. So what happens is that as healthcare spending goes up, premiums go up, employers shift more costs to employees, disposable income goes down, and in some cases, insurers even stop kind of offering health insurance at all, increasing the risk, the need for public insurance such as Medicaid. But of course, high healthcare spending also puts pressure on Medicaid to be cut. And so ultimately, rates of underinsurance increase. High healthcare spending also has an opportunity cost, which is that every dollar spent on healthcare is not a dollar that you can spend on some other important social cause, for example, education or roads or those types of things. Now, all of these trade-offs might be acceptable if the $4 trillion that we spend every year on healthcare bought us enough health, But there's ample evidence that outcomes attributable to the US healthcare system are uneven at best. For example, in a series of Medium articles, McGlynn and Mangione-Smith found that only half of adults and children receive recommended care. There's also evidence from Martin Makari at Hopkins that medical errors are a leading cause of death in the US. There's also an international perspective that can help us understand whether high healthcare spending is getting us enough health. This basically graph from the Commonwealth Fund shows the percentage of GDP spent on health among OECD countries in 2021. You can see that the overall average is 9.6%. US is an outlier at 17.8%, which is by far higher than any other country. And at the same time, the Commonwealth Fund also ranks us dead last among 11 wealthy countries in healthcare outcomes attributable to the healthcare system, potentially because we do so poorly on things like access to care, efficiency, et cetera. So really, it seems pretty clear from all this that we could be getting better returns for our healthcare dollar. So if it's important to prove value, how do we do that, right? So here, I think it's helpful to rewrite the value equation, recognizing that spending, the denominator, equals the price of a service multiplied by the quantity of a service summed over all services. So it follows that you can improve value by improving outcomes, increasing the numerator. And certainly in a small scale sense, you can do that, without substantially increasing spending. So for example, clinicians can take it upon themselves to become better clinicians, to get a bedside manner, more knowledge, those types of things. But when you're talking about really major improvements in outcomes that truly move the needle, that often requires a lot of spending. For example, if you tried to implement a patient-centered medical home. And so the net effect on value is not always clear for those kind of major improvements. You can also lower price. And of course, that's a very important thing to do, but it's very difficult to do because of political opposition, fragmented payer systems, and the increase in rapidly increasing consolidation among providers and payers. And finally, you could lower quantity. And I think that this is an attractive option in the sense that clinicians and payers have the most control over this because after all, if you think about it, most utilization requires a clinician's order and it requires a payer to pay for it. Now, of course, not all decreases in quantity are going to improve value. So if you erect access barriers by not accepting Medicaid, for example, you will lower quantity, of course, you will worsen outcomes and value. If you decrease high value care, such as immunizations, you will also lower quantity, but at the same time worsen outcomes and value. So the key really is to decrease low value care. So remember, for that very first subtype of low value care that I kind of mentioned, which is care that does not improve outcomes, eliminating that care could actually reduce spending while actually improving average outcome, which is kind of a rare win-win. And at the same time, for that second type of care, which is not cost-effective care, even though it has a positive benefit, if you eliminate that care, you can minimally change the average outcome for most patients while freeing up dollars for other purposes. In my mind, achieving these valuable ends are why it's important for us to care about reducing low-value care. Now, everything I've said so far applies to value across the age spectrum. Are there particular reasons why we should care about low-value pediatric care specifically, especially given that spending for children is just, quote unquote, just 12% of US healthcare spending? The answer is that even though US pediatric healthcare spending is small relative to that of adults, it's still large in an absolute sense. So in an editorial that Gary and I co-authored in JAMA a couple of years ago, we pointed out that 12% of US healthcare service spending actually corresponds to $277 billion. And just to put that number in perspective, that's actually more than any other OECD country spends for its entire population on healthcare, except for Japan and Germany. It's also more than half the annual US defense budget, and it's 1.7% of GDP. If you assume that 10% of that $277 billion is low value, which is probably a conservative estimate, given that others think that the burden is much higher, then it would follow that $27.7 billion was spent in 2012 on wasteful pediatric care. For that same amount of money, you could have funded universal free kindergarten or paid family leave, right? So the point is that even if the savings appear to be small in a relative sense from reducing low-value care compared to low-value care in adults, the absolute kind of savings to society could be large. Okay. There's another key reason why we should care specifically about low-value pediatric care, which is the unique nature of iatrogenics harms in children. So this comes from two things. The first is that children are developmentally more vulnerable, and the second is that they have long expected lifetimes, which means that there's a longer horizon over which iatrogenic harms can manifest. So the classic example of this is medical radiation. This is thought to be associated with a higher risk of lifetime malignancy, not just because children are growing and their cells are still dividing, but also because they live longer. And of course, that means that there's a longer horizon over which you can develop cancer. In short, the ability for us to achieve substantial absolute cost savings to society while avoiding iatrogenic harms to children are the unique reasons why we should care specifically about reducing low-value pediatric care. Okay. I'm going to move on now to some of my empirical research on this topic, demonstrating kind of the prevalence and financial burden of low-value pediatric care. Okay, so I think it's helpful for me to set the table in a sense by describing the state of the landscape of the literature on low-value pediatric care. At the time I started doing work in this space around 2015. So at that time, most of the studies on low-value pediatric care were focused on documenting unexplained variation in pediatric care. So for example, the Dartmouth Atlas group found that children in Lebanon, New Hampshire were 2.7 times more likely to undergo tonsillectomy than children in Burlington, Vermont. There were a number of studies using the FIS database showing unexplained variation in care for common pediatric conditions like asthma, bronchiolitis, and urinary tract infections. And there were also studies showing variation in length of stay in the neonatal intensive care unit that was not explained by differences in patient severity. Now, all of this literature, in my mind, constituted indirect evidence of low-value pediatric care. And the reason I say it's indirect is because there is some that we would expect some degree of variation that's appropriate simply based on differences in patient need. The question is how much, right? And we would be able to answer that question if we could perfectly adjust for patient need, but we usually can't do that because especially if we're using administrative databases. And what that means is that the ideal rate of use becomes kind of unknown, right? We don't know whether the high utilizers are overusing care, whether the low utilizers are underutilizing care, or both. And so for that reason, it's useful to directly measure services in which the rate of use should be 0%. Because any deviation from 0% likely constitutes some degree of overuse. And at the time that I started doing work in this space, pretty much the only direct measure of low-value pediatric care that I was aware of were the HEDIS antibiotic overuse measures that are used for reporting health plan quality. So in a paper that I published just before I got here at the University of Michigan, I set out to develop 20 new measures that directly identify low-value pediatric care in claims data, and then to use those measures to estimate the prevalence and financial burden of low-value pediatric care across a variety of settings, conditions, and treatments. The reason I focused on claims is because claims data are population-based, they're longitudinal, and they have information on spending, which makes them ideally suited for a study estimating the prevalence and financial burden of low-value pediatric care at the population level. So in order to kind of develop these 20 measures, I started by compiling over 400 candidate low-value services. For example, I looked at the Choose Wisely recommendations, which was a national initiative in which all the US specialty societies, medical societies published a top 5 list of services that clinicians and patients should avoid. I looked at the US Preventive Task Force Grade D recommendations, the National Institute for Health and Care Excellence Do-Not-Do list, clinical practice guidelines from the US specialty societies, and evidence reviews from the Cochrane Collaborative. After compiling this massive list, I ended up excluding most of them simply because it wasn't feasible to determine appropriateness of claims. So for example, IV fluids are commonly overused for children with gastroenteritis, but any given application of IV fluids might be appropriate if the patient was severely dehydrated. And unfortunately, you just can't ascertain that severity of illness in claims. So after culling the vast majority of these, I settled on 20 measures, of which 6 were diagnostic tests. So for example, vitamin D testing, allergy testing for kids with eczema, RSV testing in children with bronchiolitis, blood testing in kids with simple febrile seizures, cervical cancer in female adolescents, and group A strep A testing in children less than 3 years old. I developed 5 low-value imaging test measures, including things like X-rays of the face and head trauma, ultrasound for children with undescended testicles, sinus imaging for acute sinusitis, and neuroimaging for simple fibrotic seizures and headaches. And finally, I had 9 low-value prescription drug measures, which included cough and cold medication use in young children, antibiotics for colds, otitis media with infusion, swimmer's ear, tonsillectomy, bronchiolitis, steroids for bronchiolitis, short-acting beta agonists like albuterol for bronchiolitis, and acid blockers for infants with uncomplicated reflux. So just to give you a sense of what some of these measures look like, the oral antibiotics after tonsillectomy measure was specified as the percentage of children undergoing tonsillectomy with at least 1 dispensed antibiotic prescription on the day of surgery or within the subsequent 3 days. And in order to maximize specificity, i.e. only identify truly inappropriate antibiotic use, I excluded instances in which there was some other diagnosis code like ear infection or something like that, but that potentially might warrant oral antibiotics during the 3-day search period. And I also excluded kids that had complex chronic conditions, because some of those kids are immunocompromised and may actually warrant antibiotic prophylaxis after surgery. So after I developed those 20 measures, I applied them to a database called the IBM Market Scan Commercial Database, now known as Narrative Market Scan Commercial Database. And this is a database that includes about 45 million privately insured patients across the US who receive insurance from their employer. The sample was 4.4 million children aged 0 to 18 years who were continuously enrolled in 2013 and 2014. I only used 2013 as a look back period for prior diagnosis codes. That 4.4 million number constitutes about 11.9% of all privately insured children, so about 1 in 8 kids in the US with private insurance. The main outcomes were the proportion of children receiving any of the 20 services at least once in 2014, and aggregate spending and out-of-pocket spending across the 20 services in 2014. And by spending, what I mean is the sum of out-of-pocket spending by the family and insurer reimbursement to the clinician. So what I found is that about 9.6% of the sample of the 4.4 million children, or about 1 in 10 children, received any of the 20 low-value services at least once. About 4% received any of the low-value diagnostic tests. The diagnostic tests, 0.4% received any of the imaging tests, and 6% received any of the low-value prescription drug measures. The most prevalent services in the sample were oral antibiotics for colds, which affected 3.2% of the 4.4 million children, testing for group A strep in young children, screening for vitamin D deficiency, oral antibiotics for otitis media with infusion, and acid blockers for infants with reflux. And then if you look at the measure level, here are some examples of measures in which the rate of low-value care was actually quite high. So for example, among all children with a diagnosis for upper respiratory infection, 18.2% of them received an oral antibiotic within 3 days. 12.9% of all young children were tested for strep at least once in 2014. 40% of kids with the diagnosis of acute otitis media with infusion received antibiotics. About 28% of children with bronchiolitis received prescriptions for albuterol or other short-acting beta agonists. And 5% of all infants, or 1 in 20 infants, were prescribed an acid blocker like Zantac or a PPI like omeprazole during 2014. If you look at total spending was $27 million in our sample, of which 9.2 million was out of pocket. So about 1/3 of it was borne by families. And if you look at the kind of drivers of total spending, you can see in the lower right, the blue shaded portion of this pie chart, imaging tests accounted for about 1/3 of that $27 million, even though, remember that 0.4% of the sample received low-value imaging tests, demonstrating how costly they can be, those tests are, at least in society, even though they're not prevalent. Yep.
Was there of the 3 different types of the overuse measures, was there a certain type that had a higher proportion out of pocket than others?
Yeah, did I look at that? My sense is that it was the imaging tests because they're the most expensive and they're most likely to result in somebody exceeding their deductibles. But I don't know that that's, I mean, and that makes sense, right? Because most prescription drugs, most people pay like a relatively low copay, $10 or something like that. So maybe that's, if you look at that as a proportion relative to the cost of the drug, maybe it's pretty high, right? Because maybe it's a generic drug, it doesn't really cost that much. But if you're thinking about like on a per service basis, by far the imaging tests were the ones that dominated that. Yeah.
And does this assume that all acute otitis media with effusion should never be treated with an antibiotic?
That is what well, I made a lot of exclusions and I excluded any case where, patients had chronic otitis media, a previous course of antibiotics. I mean, it was trying to be very specific. So what I think I was measuring are cases that were just AOM with no other reason for it. And the answer is, yeah, if you code tick, if AOM actually, if the presence of a code for acute otitis media truly means that the patient has acute otitis media, which is an assumption, right? Then no, you shouldn't get any antibiotics. Because it's not effective, right? There's ample evidence that antibiotics don't do anything for that. And just for the non-clinicians, that's fluid behind the middle ear, essentially what that is. It's usually a function of dysfunctional eustachian tubes from a cold, for example. It's not infectious. That's the point. Okay, so what this is showing in summary is that about 10% of children, privately insured children, receive at least one of the 20 low-value services in 2014. And if you think about it, that should imply to you, at least it implies to me, that waste in pediatric is pretty widespread because this is just 20 measures, right? And we were still able to see a pretty high population prevalence. 1/3 of spending on low-value care was borne out of pocket by families, which shows that there are some financial burdens of that essentially wasteful pediatric care can harm families potentially financially. And even though spending in the sample was only 27 million, remember our sample only constituted 1 in 8 privately insured children, right? So if you extrapolate that to all privately insured children, you end up with an estimate of about $227 million just for these 20 low-value services in privately insured children. And of course, that does not include spending by Medicaid patients, right, who are not included in this study.
Is there any research around what low-value care would look like in Medicaid versus commercially?
Yes, there is. I'm about to mention that. I'm not going to cover it, but yes, hold that question. So it's obvious to anybody who does claims-based research that there's always a risk of misclassification. And it works both ways. You could misclassify some appropriate care as inappropriate or some inappropriate care as appropriate, right? This is just unfortunately the Achilles heel of doing any sort of administrative analysis of healthcare quality and appropriateness. This study definitely underestimates the proportion of children receiving low-value care. And I know that because 3 years later, I published a study that basically just looked at the proportion of privately insured children receiving just inappropriate antibiotic prescriptions, not just the measures that I looked at, right? For colds, just any inappropriate antibiotic prescription. And it turns out that 11% of children received inappropriate antibiotics each year, okay? Which is higher than the 9.6% that I showed in the pediatric study, right? And then, of course, at the time I published the original study, I did not examine the public insured, but in a follow-up study in 2020, I used MAX data and market scan data from 12 states to compare the prevalence of the 27 services by payer type. And it turns out that there was a higher rate in publicly insured children, mostly because of prescription drugs measures. But the overall difference of 2.2%, while that's not trivial from a population level, it's not huge, right? And so kind of just suggests that waste in pediatrics is widespread, regardless of payer type. Okay, I'm gonna move on now to why does all this occur, right? So the question I'm going to try to kind of get at is, if reducing low-value pediatric care is such an obvious win-win, why does it appear to be so prevalent, right? The answer is that, so this slide, for example, basically shows, it's from a study by Morgan in BMJ 2015, basically listing all the various drivers of low value care. So they're both provider factors, patient factors, intrinsic, extrinsic. They're things like defensive medicine, not wanting to get sued, there's not enough time, there's this belief that more care is better, et cetera, et cetera, et cetera. So these are all very important reasons. But I would argue that there is a missing reason on this slide, which is that there's a disagreement about the definition of low value care, which is that low value pediatric care or care in general appears to be so widespread because the people who are ordering that care don't think it's low value, right? It's essentially a disagreement about what constitutes low value pediatric care. With kind of a few exceptions, I would argue that clinicians generally believe that they're acting in patients' best interests. And unfortunately, those actions can sometimes conflict with somebody else's definition of appropriate care. So, another way to think about this is that while the kind of the value equation seemingly seems very simple on its surface, actually, when you think about the numerator outcomes, it's actually kind of a complicated question because when you're measuring outcomes, you have to kind of make decisions about which harms and benefits you include and how they should be rated against each other. And so here's an example, head CTs for children with head injury. So reducing unnecessary imaging in this setting is really important because of course, imaging is expensive, so you can reduce spending. And of course, you want to reduce iatrogenic exposure to unnecessary radiation because as I've mentioned before, this increases the lifetime risk of cancer. It's such an important kind of priority that the AAP, American Academy of Pediatrics, one of their choosing wisely recommendations says, don't always use head CT for immediate evaluation of children with minor head injury. Rather, we should be using clinical decision rules like the ones developed by the PCARN initiative. So the implication of the AAP statement is that routinely obtaining a head CT for kids with head trauma is low value care, right? So that is a simple statement on its surface, but when you actually kind of break it down, it's actually kind of more complicated than that. So this table shows the potential benefits and harms of routine head CTs for children with head injury for patients and family and society. And for patients and families, I further subdivided it into physical, emotional, and financial benefits and harms. So for patients and families, there are some benefits. The physical benefit is that there's a small possibility of detecting a clinically important bleed, right? A traumatic brain injury. From an emotional standpoint, there's the reassurance factor, right? Parents knowing that their kid is not going to kind of herniate, right, when they go to sleep. There's not really much of a financial benefit to patients and families, but there might be to society if head CT prevents spending associated with misdiagnosis, right? On the flip side, there are harms, right? So to patients and families, the physical harm is increased risk of iatrogenic radiation-induced malignancy. There are emotional harms to children because imaging can be frightening. There are financial harms in the form of high out-of-pocket spending for imaging. And also to society, there are financial harms because imaging is very expensive, right? So any given clinician may choose only to, clinicians essentially vary in terms of which of these harms and benefits they care about. And they also probably vary in terms of how they weigh them against each other. So for example, there may be some clinicians who believe that the value of reassurance is so great that it outweighs everything else. And so, and then there are other clinicians who may think that the small possibility of avoiding missing essentially a clinically important bleed outweighs everything else. So for those clinicians, getting a routine head CT is actually high value care, not low value care. Lisa.
Yeah, so I just wanted to add, so I think that, that second row that you have there about reassurance, which you could also describe as the value of information, because there are many cases, especially for diagnostic tests, where patients, families, and clinicians, can place a value. You can even measure that value of the information. And I think what's really important there is what you just said, that there are some clinicians who would place a high value on that. Also, some patients and families, that this is where, the distribution of values is highly heterogeneous. And so it's really preference sensitive. And so just something to consider.
Yeah, that's a really good way of putting it. Like value of information it's more general than reassurance specifically. I think that's right. Okay, so this ends up being a little bit of a dicey proposition to claim that it's that it's always low value, right? It depends on how you look at it, right? So let me just kind of throw out some other slides that might kind of illustrate part of the problem in this case, right? Which is that part of the issue here is that the net benefit of a head CT, of a policy of universally getting a head CT for kids with head trauma, the net benefit varies, right? So for the vast majority of people, it's negative, right? You're worse off, right? Because you've been exposed unnecessarily to imaging, right? But for this very small group, right? The 1 in 1,000 kids, right, who have a clinically important bleed, right? Head CT is incredibly useful, right? And so depending on how you weigh the harms to the many versus the benefits to the few, you could come up with a very different conclusion about whether universal head CT is low value care or not. Now, let me show you a different example, which is, say there was a service in which 1% have very negative net benefit, 10% have somewhat negative benefit, but 89% have somewhat positive net benefit, right? So it benefits most people and harms a little bit, 10%, but it really harms 1%, right? So this actually turns out to be roughly what the distribution of coding, of benefit for coding in children. So the reason for this is that coding metabolism varies widely due to genetic polymorphisms. About 1% of children ultra rapidly metabolize codeine to morphine in the blood, which causes this really huge blood spike in morphine and causes them to overdose and potentially die. 10% of children have slow metabolism, meaning that they don't actually get much of the analgesic, the kind of the pain relief from codeine, but they get some of the side effects like constipation. And so they're kind of like negative net benefit. And then you have 89% of children who actually respond very well to codeine. You get the intended analgesic effects. And so their net benefit is pretty high. Now, a couple years ago, FDA basically issued a black box warning that says, do not ever use codeine in any case for children under the age of 12. This was in 2017. Despite that, an analysis of IQVIA data that I did in 2019 shows that in 2019, 7% of opioid prescriptions to children under the age of 12 were for codeine, right? Despite this black box warning. And I think a reason for this is because for most clinicians, they think, okay, well, the risk of this kind of ultra rapid metabolism and these catastrophic side effects is pretty low compared with the benefit that I'm going to be able to provide to most children. So I think that's my theory. I don't know that for a fact, but that's my guess. Yeah.
And I would just also add, oftentimes clinicians interpret those black box warnings as caution, not contraindication.
That's right, yeah.
Right, and so if you had a patient where you felt like the codeine would be very beneficial and you put in safeguards to monitor for the 1%,
Yeah.
you might feel that that's a very appropriate way to go.
If you could actually characterize, and you can, there are blood tests, of course, right, for these polymorphisms, you can actually identify who's ultra rapid metabolizer, and then just not give that. So we just don't have that capability right now, and honestly, so few children generally need opioids and codeine in general that it's probably not worth universally running that test on everybody. So it's not practical for us to run that test before we prescribe codeine. It's just not. So, but to your point, I think you're right. FDA, this was the contraindication. It was like contraindication is their strongest warning. It's really basically saying do never, ever, like never, right? It's not the kind of just warning that, these drugs are associated with an increased risk of whatever, right? Okay, so I think the point that I'm trying to make is that low value care seems easy to define in theory, right? But when you actually try to operationalize it, it's quite difficult because you have to make these decisions on which harms and benefits to consider and how to weigh them against each other. And this is inherently controversial because providers have different values. This ends up being a real challenge for research, such as the one that I do, because you have to choose an external standard of appropriateness, because if you say value is in the eye of the beholder, then there would be no such thing as low value care. Couldn't measure it, right? At the same time, you must acknowledge as a researcher that what you're measuring as low value care is often care that clinicians thought was actually reasonable. This is also a challenge for quality improvement, because if clinicians don't think that what they're doing is low value care, you're not gonna change their behavior, right? Okay. I'm gonna end just talking about what we can do to reduce low value pediatric care. And I'm gonna be start by being a little bit more specific by what I mean by we. Payers and policymakers generally are gonna have limited interest in pediatric focused efforts to reduce low value care. And the reason is not again, it's not that the absolute savings couldn't be large, it's that the relative savings compared with reducing low value care in adults, it's just not favorable, right? Now, children could, there may be cases in which children may come along with the ride in some waste reduction efforts. So for example, there are some accountable care organizations that include both children and adults. Some insurers may deny coverage for certain services regardless of age. So there are some things where children are affected indirectly, but it's highly unlikely that there's ever going to be a lot of primary efforts to kind of reduce low value pediatric care specifically. Which to me then implies that change needs to be driven by those within the pediatric profession, researchers, clinicians, people like us, right? So what can we do? So there's a couple of steps that I think that might be important. One is to provide better evidence on the benefits and harms of interventions in children using clinical comfort effectiveness research, precision medicine. If we can really understand what is and what is not effective, it will be easier to build consensus on what is and what is not low value pediatric care. I think we could do a better job of using shared decision making. This is not a panacea. I just want to caveat that. In some ways, because it's really hard to convey the benefits and harms of interventions. And in some cases, people don't want shared decision making because they already have made up their minds or actually don't want to make the decision themselves, right? But that being said, there is evidence primarily from the adult world that shared decision making can prompt patients to decline low value interventions and at the minimum prevent providers from ordering low value interventions because they misunderstand patients' preferences. We need more research evaluating interventions to reduce low value pediatric care. So this graph comes from Kerry Kalla's MCRR review in 2016 on whether various interventions to reduce low value care were effective, uncertain, or ineffective. You can see there's all sorts of different types of interventions, but almost all of these came from the adult world. Most of what there has been, I think in recent years, I've noticed a few more, like a little bit of an uptick in studies that look at low value pediatric care specifically, especially in the context of antibiotic overuse, opioid overprescribing, and bronchiolitis care. Those are the three ones that I've seen the most. But the point is we just don't have enough empirical research to know what is and what is not effective in pediatrics specifically. I think it's important to use language. This is a little bit of a subtle point. It's important to use language that appropriately frames the magnitude of pediatric healthcare spending. So this is a point that Gary and I made in our viewpoint a couple of years ago. If it's really common to hear things like pediatric healthcare spending is just 12% of US healthcare spending, or pediatric healthcare spending is just rounding error, right? That's my favorite one. The problem with that kind of relative language is that it frames pediatric spending as small. We get the sense that it's small relative to something else, even though it's really large in an absolute sense. And so if we can kind of use more appropriate language, it will be easier to convince pediatric clinicians of the importance of reducing low value care. I think there needs to be a culture shift in pediatric medical education in which cost-conscious care becomes like a core kind of skill where essentially the ability to parsimoniously choose which diagnoses to rule out is rewarded just as much as the ability to come up with a long list of things that something could be, right? The differential diagnosis. And if we can kind of train pediatric providers, young ones, to routinely incorporate the idea of choosing wisely into decision making, that'll make, I think, a great difference in the long term. And I also think it's important for researchers to continue monitoring levels of use of both old and new types of low value care. So the importance of monitoring new types of low value care was highlighted to me during the COVID pandemic because unfortunately COVID itself became a source of low value care. So my favorite example of this is the spike in ivermectin dispensing for COVID-19 infection. So this graph comes from IQVIA data. This is a national prescription dispensing database. And it shows weekly dispensing of oral ivermectin prescriptions from March 2019 to August 13th, 2021. So what you see is that pretty much nobody ever used oral ivermectin before the pandemic, right? It just wasn't that used. You use it for like parasitic infections, right? So it's very uncommon, right? But by August 13, 2021, we went from a baseline of 3,000 prescriptions a week to 88,000, right? And so in this is my favorite study that I've done so far, even though it's like the least methodologically rigorous study I've ever done. I did a study that basically used the claims data to estimate how much insurers were wasting on these 88,000 prescriptions, right? And I estimated that private and that's Medicaid, it should be Medicare. Private and Medicare plans spent $2.5 million on these ivermectin prescriptions for COVID-19 just in the week of August 13, 2021, which if you extrapolate that over the course of a year is more than $100 million, right? So what I'm worried about is, now while we I think in recent times, I know that ivermectin kind of dispensing has kind of gone down. What I'm concerned about is like the fact that it existed in the first place just kind of means to me that there may be a breakdown in trust in the scientific process and evidence. And so I wonder, I'm a little bit concerned that we may start seeing a little bit of a spillover effect on old types of low value care as people start to kind of increasingly distrust the medical system. So that's why I think it's important not just to monitor new cases, types of low value care like ivermectin use for COVID-19, but also to make sure that we're not sliding backwards in terms of older forms of low value care. Now, I want to just, of course, say that all the steps that I've outlined are difficult. There is no easy fix, but I do think that there are some success stories. So a couple years ago, I published a study that evaluated trends in dispensing of opioid, cough, and cold medications to children aged 0 to 17 years from 2014 to 2019. Part of the purpose of this was to evaluate the effects of 2 FDA warnings against the use of these medications in children in 2017 and 2018. So there were a pair of warnings that came out in 2017 and 2018, basically saying don't use these drugs, right? And so this graph shows codeine, cough, and cold medication dispensing at the monthly level from 2014 to 2019. The 2 vertical dashed lines are the correspond to the timing of the FDA warnings. What you see is that essentially by the end of the study period, there was no dispensing of these medications. The 2 warnings actually in an interrupted time series analysis were not actually associated with reductions in dispensing trends, which implies to me that there was something else going on internally within the pediatric community that drove this change, right? That we didn't need external kind of government intervention to make this happen. Somehow the clinical enterprise, clinicians just were managed to eliminate this. And actually, I'm not showing the hydrocodone results, but it's basically the same, right? So this shows that it is possible, albeit certainly still challenging. That's it. Go ahead.
So when you talked about like the benefit of information or that reassurance aspect of patients and families driving care, what is the balance when it comes to like the provider as they know like things like this and then having to deal with like I guess like the evaluation of care, but also like families pushing back or things like that, because you want the families and patients to have autonomy, but you also don't want to have this waste. So clinically, kind of what are some recommendations or how do you handle that?
So I think that, I can answer that from my own personal perspective about what happens when patients push me for antibiotics for something for their cold or whatever like that. I think part of it is just like knowing that you're gonna annoy some people, right? Being willing to accept that your job as a clinician is not to make everybody happy, it's to provide the right care. Even if that, makes your Press Ganey satisfaction scores worse, which it might, or jeopardizes an ongoing relationship, right? Sometimes you're talking to families that you've seen multiple times and they may not see you after that. There's some costs, right? I think that it doesn't always have to be like, take it or leave it, right? There are ways to kind of frame this in a way that's saying like, look, you know, my primary goal is to prevent unnecessary harm and do the right thing for your kid. I just don't think this is the right thing. I don't think it's needed. I'm worried about the side effects. And so can we just wait a little bit, right? So there are some middle ground approaches. Fundamentally, it's hard, right? Fundamentally, it takes some commitment, I think, to that. And honestly, when you're tired, you're rushed, you have 10 minutes, you're late, because previous patient went to 40 minutes, so I was supposed to take 15. It's just sometimes easier to provide that prescription, just being honest, right? You just have to have that discipline. So as from a clinician, I can answer that better than I can, like what can family do, right?
Mary and then Kevin.
So I agree with you 100% about having the discussion with families. You gotta do it, period. What I was thinking was, this is important low value care, no question. But it's also the tip of the iceberg in terms of the whole like supplement industry and vitamins and things that we also recommend sometimes, or that we don't necessarily actively dissuade.
Yeah.
Which, and I don't know the exact numbers, but I fathom, because of knowing just the industry of useless supplements, you know, that's bandied about, and I know that, like, you know, not just me prescribing the, you know, anti-reflux medicine, but all the ones that they buy without me ever prescribing it dwarf whatever I don't prescribe, but I think we prescribe. And I was just wondering if you have any thoughts about low value care, like the big fish of low value
I
care.
think that if we were actually to measure
Like
every form of low value
all
care,
that.
yeah, I think it would be way higher. Probably close to 75% of kids getting low value care each year.
I would say at least.
At least, right? I mean, it's not like, sometimes it's like, honestly, there's the Australians, as you know, would argue that all of the well-child checks that we do are low value care, right? So there, and honestly, for some of those visits, I would agree, right? The 9-month visit always bothers me, right? So just like, what are we doing? And I'm just waiting to be, sorry. But
They also
to
miss a
your point,
lot of developmental milestones.
They do,
Yeah.
but I mean, yeah, I get it. So I just think that,
It's a debate.
it is a debate, right? And I just think that if we were to really measure everything, right? If we could measure everything, there would be a lot more low value care than this is.
Yeah, it's the tip of the
Totally, it's the iceberg. It's what you can measure, maybe feasibly, maybe
Yeah.
in claims. Like I said, there's over 400 other services that I threw out because I couldn't do it.
Yeah.
I just didn't think it was feasible.
I have a question and then we can go to Kevin's talk, just because mine goes off of Gary's. You know, I like to think about population things, you know, what happens before someone steps into a doctor's office, right? Has anyone ever done anything around? Because I mean, it's low value care to go to a doctor when you don't need to also, right? Like
Yeah.
your kid has a fever for 6 hours and you show up, like, is there anything that is ever quantified how much actual face-to-face outpatient care is unnecessary?
Yeah,
low value?
that's a really good question. I'm not aware of anything in the pediatric literature. I know that people like Alan Schroeder and from Stanford have done stuff like unnecessary follow-up visits for bronchiolitis, like after what he considers low value follow-up visits after hospitalization for bronchiolitis, right? And so that was
Unnecessary ED visit.
What's that?
Some unnecessary
Sure.
ED visit.
Yeah. ED visits was been on one, but the outpatient care, I think,
Harder.
I guess I'm most aware of like the literature looking at what percentage of ED visits could have been seen in a primary care setting, but that doesn't answer the question of how many of those primary care visits were actually just a waste, right?
Now they're all turning into portal
Messages
messages.
instead?
Yeah. No, it is true, right? Yeah, portal,
Bane of our existence.
yeah,
I'm sure.
yeah.
And then Kevin has a question. Do you think that there may be opportunities for best practice alerts, BPAs delivered by the EHR to flag low value tests or prescribed meds? have BPAs been used for adults or kids to reduce the use of low-value services?
Yes, I do think there is opportunity. So I'm not gonna, this is not exactly a best practice alert, though my entire K award was actually about this is not a best practice alert, but it is essentially utilizing the electronic health record to lower the default number of opioid doses and opioid prescriptions after surgery. And in my case was adolescents, young adults undergoing telectomy, and it worked, right? People, you change the default number of doses from 30 to 12, people start prescribing 12, right, instead of 30. So I think there are definitely opportunities in general to leverage informatics and the EHR to reduce low value care. There was, in the adult literature, there was a randomized trial that I think it was, maybe they did this in children too. I'm just trying to think. I think Jeff Garber might have done at CHOP, may have done a study looking at requiring justification for your antibiotic, like some sort of thing where you had to justify why you were writing an antibiotic, and how that may affected rates of antibiotic use. And it appeared to work, but then I think the result of that was when the intervention was withdrawn, it kind of went back to baseline. So
part of it, Kyle, of course, is when you start tracing this back, I guess the precursor to my questions are, what are the root causes you outlined? And I don't know if you actually put numbers on it, but things like, okay, let's say I as a clinician just flat out disagree. I believe that fill in the blank really works, and I don't care about the low value sort of label that somebody assigns this, the task force or whomever assigns to this. That's one thread. The other is the reassurance, that, some reassurance may be warranted in certain cases for parents, and that's why clinicians maybe cave in. I don't know. But do we know, and maybe you presented that, I just missed it. Do we have some sense of sort of like the proportions? Because BPAs aren't going to work if it's not a clinician focused issue, right? If you're
that's right. If it's coming from the patient, right?
Yeah, it doesn't work, right?
Yeah, you're gonna override it. You're gonna say, "Our patient requires reassurance," but I'm gonna type something else that makes it seem like
Right. And the last thing you need is another BPA probably for something, so.
Yeah. I mean, I think the reassurance thing is, I think this is an underappreciated contribution of pediatrics to society is mental health of caregivers, right? Our mental health caregivers, like to parents, right? That is fundamentally part and parcel of what pediatricians are, which I agree. But that's not always that cannot be the only value, right? That cannot be the only good that we prioritize. And so it's this complex juggling act. I think this gets to my point. It's hard, sometimes it's hard to really be too hard on people, ordering stuff, right? I remember there was a colleague of mine in the ER who was like, he knew that like kids with a seizure, coming with seizures or whatever, didn't need anything, right? Kids with a fever didn't need anything. Always offered blood testing, always. And I was like, why do you do that? And she was like, well, it's reassurance. Because in her mind, that was the primary purpose. Can I argue with her? I can. I disagree. Do I think she was a horrible person? No. I just maybe for a different sense. Right. But I just, you know what I mean? Like it's just there are different value sets. And this is what makes this area of healthcare so difficult.
And first-time parents are different than other parents too.
Absolutely, yeah. Absolutely, yeah. You've been through it?
When they come to the specialist, we always get labs because that's part of the
What you
process, right? Like,
It's just what
if I agreed with you and I didn't order labs, there wouldn't be reassurance.
Yeah.
Right?
No, it's
So,
And so sometimes, we make stuff.
So I was wondering, there's a lot of variation and the lack of standardization of processes contributes to having like all this low value care. And so it might be a form of market failure, and having the policy, state level policies or federal policies intervene to help with this failure might help. So maybe like if you channel part of your efforts towards informing policies like payment or financing mechanisms, health system financing, that could really impact physicians or clinicians practicing patterns, like ACOs, for example, accountable care organizations or P4P mechanisms, these would, like, even if the physician would think this is very important, but whenever a capitation program is in place, they would have to rethink before practicing.
Yeah.
So that might be something.
Yeah, so if I'm hearing you correctly, it's like, if we reorganized how clinicians were incentivized, right? Moving away from fee for service towards a global kind of payment system where you're not paid for more care, you're actually paid for less care, at least while preserving quality. Better care while preserving quality in theory, right? Maybe we can make some kind of headway there. Maybe we can have pay for performance kind of systems that reward reductions in low value care. I think those have been trialed and those are certainly on the table. I'm just reminded of a recent thing that Blue Cross Blue Shield did, where there was actually an incentive paid to surgeons to use an opioid sparing pathway after surgery, right? So that sounds fine, right? Except that the way that Bridge, Michigan wrote the study was insurers pay doctors more money not to prescribe opioids. And so there is a little bit of like, you have to be careful, I think, one has to be careful with the optics of this to the patient, right? Because and that's why I'm not exactly sure that incentives, I'm not always sure that incentives are like the best way to go. I think that I think a global system potentially like that has incentive where has a little bit more potential than a direct financial incentive. Does that make sense? If that makes sense, but there's a lot of literature on this.
Four things. Thank you, Kao, for your talk and for stepping in. I have two quick clinical things about Kao. I'm at the age where all of my friends' kids are getting their tonsils out. And one said to me, it's so weird. This was just a couple weeks ago. I only got a prescription for 12 opioids. And when my other kid, I got 30. Seriously, because she's a nurse and she thought it was so funny. So it's very interesting to see, like, I said, I know who did that. But I did not give your name, don't worry. And the other thing is that I recently had my kid at the pediatrician and made a comment about Kao, and whoever it was goes, that guy sure hates low value care. And that was my favorite comment so he practices what he preaches about everything.
I try, but look, we try, we all try.
Yeah.
I am not perfect and I would never claim to be, but
But I think it's nice to
I think
see
it's important to try.
consistency
It's important to
across all aspects. There's a QR code. That's the fourth thing to fill this out. It helps us all get promoted someday. So please fill that out. And the survey link is in the chat if you are there in the chat. Thanks. 11, it's my favorite when everybody pulls out their family members. So. We should ask people if they want this.